start the class, I had sent a couple of things on the Telegram channel, my channel, last night, and I expected people to read it through because that's very, very important regarding Plan A, B, and B plus of WHO, not just WHO, also accepted by NAP. Tonight, the class is going to be on HIV in pregnancy, and I have made sure that I always, take first the Indian guidelines, and then maybe if it's not available, then go in for the European guideline or the American guidelines. Why I do that is because we as Indian people have a typically different climatic conditions, geographic conditions, biological conditions, our growth potential, BMR, everything is very different from what it is. And of course, we are a low resource setting, not to not mention that, a developing nation. So everything which might be a recommendation or a guideline abroad might not work very well in Indian scenario. So I always go ahead first for the Indian guidelines and then maybe the European or the American systems. So good evening and welcome everybody to my class today, and it's going to be on HIV in pregnancy. I hope you people have already read the two messages I sent earlier on my Telegram channel. They were about the Plan A, B, and B plus of recommended now by WHO and also incorporated by NACO, which is an Indian association, and we go ahead and studying their recommendations in tonight. The class on HIV. So we go ahead and endorse and accept and imbibe all those recommendations given by WHO and then by NACO, and then go ahead and devise a plan for the pregnant patient who is HIV positive. So let's begin tonight the class on HIV concerning everything in minute detail about HIV virus, which is a very, very important virus, and your exam has multiple times in different ways asked this question about HIV. I hope I'm loud and clear, and if you're feeling that there is any disturbance in my class, please go ahead and tell me. If you're not able to see the screen properly, please be frank and let me know if there is any kind of problems. Now, we begin with the introduction of HIV, which is an RNA retrovirus, and it causes very serious infection, which in about 8 to 10 years. Now, this is the good thing about HIV infection, that it takes some time to develop. And by some time, I mean 8 to 10 years or even more. Okay. And the immunity initially to start with was good, then it will take even more time to grow into full-blown AIDS. We are going to be discussing that later in the chapter. So, which is obviously by acquired immunodeficiency syndrome. It's an immunodeficiency syndrome. How it happens, we're just going to discuss about it, the etiopathogenesis, in which the immune system is so depleted that unusual bacteria and the viral infections, they start attacking our body, and we finally succumb to those infections. So let's just a brief view of what is the epidemiology. So HIV is increasing in all countries. It's a global problem that we know. We have the latest, statistics of 2012 by WHO, and according to that, there were around 35.3 million people who were infected with HIV, amongst which 50%, which is a good figure, was the females. And there is a reason why so many females are, infected with it. Not just because they're cohabitating with those males who are HIV positive, but also the fact that females require a lot of blood and blood products during some point in their life, because they bleed during the delivery or due to abortions, or because of so many reasons, ectopic pregnancy, sometimes septicemia, sometimes illegal abortions, that they have the requirement for blood products is more in females as compared to male. And you know that this is a blood-borne disease. It's either through drug abuse, or through marriageous route, or through blood transfusions, and of course through sexual intercourse. So because of that, a huge population of females are already infected. And when you talk about India, India has the highest population of HIV infected persons, next only to Africa, which is a very alarming figure. And amongst this also, if you talk about Indian subcontinent, you'll see the southern part, Maharashtra, Andhra Pradesh, Tamil Nadu, Karnataka. These places, they bear mostly the burden of HIV in the country. Around 62% of the entire HIV infections, they're seen in these 4 states which I just mentioned. Okay. So with this scenario, we go ahead discussing the risk factors and modes of transmission. So you know it very well. We've been discussing, this was a thing of your undergraduate level. How is it like, what is the risk factor? So these are the risk factors. Blood transfusion, promiscuous behavior of either partner would lead to more of HIV because it's a sexually transmitted disease. Illicit use of drugs, drug abuse, which is not so much obviously in females. We're more concerned about, because gynecologists here talking about females mostly. So we're more concerned about why 50% females are still harboring this infection. And this is basically, these are a couple of reasons which I see. Indulging in unsafe sex practices, and obviously this promiscuity is very, very important. A brief word about etiology and pathogenesis. So here you'll get to understand the next, slide. So this is the basis for the next slides to come. So please watch this carefully. Have a look at the structure of HIV virus over here. Amongst, when you're talking about the outside, the outer coat, do you see GP41, which is a transmembrane glycoprotein, GP120, which is a docking protein, okay? And then you have internal, this matrix protein is there and on. You have everything inside, then you have a capsid outside, okay? Then you have an envelope, a lipid envelope. And inside what you see is, you see a matrix protein, then you see this whole thing, this nucleocapsid is there, RNA genome is there, integrase is there when you talk about integrase inhibitors, fusion inhibitors. So over here you have reverse transcriptase inhibitor. So these are all enzymes which make it more lethal, and every enzyme has its own function, and that is not expected of you at this point in time to describe each and every cellular structure of HIV. That question is not expected out of you. What is expected out of you? We have a class on that today. So HIV is a retrovirus. Either you can see the diagrammatic structure. What happens is that it's a very smart virus. It integrates within the host genome on the infected host cells, and it produces multiple copies of the HIV genome as DNA. I think you must have heard this very often about the bacteriophage doing this. So it goes and it integrates with the human genome, and then it makes these couple copies, of the HIV genome actually. And the target of this virus are what? The helper, the CD4 helper lymphocytes, which start producing new virus particles, and they themselves, they lose their central role in the immune response to fight the various infections. So are you getting me? So what's happening is that the best, lymphocytes of the body, the ones who are very good in adaptive immunity, they are targeted. Once they are targeted, these, helper lymphocytes, they are the ones who lose their actual job and start doing some other job. Now they started producing bacteriophages, or let's say, the HIV genome, rather than concentrating on the main job to fight for the body. So the immune response has gone down. And now the CD4 lymphocytes are doing another, role. That's the basis of HIV, because of which so many opportunistic infections finally lead to the catastrophic, full-blown AIDS or the terminal picture of the AIDS patient. So basically, HIV causes progressive immunosuppression and ultimately the development of full-blown AIDS. Now, let's see how it progresses. Again, this is also very, very important. So please be very careful. When I am explaining you something that forms your basics, I go very slow. So please try to understand what I'm trying to tell you over here. First is the incubation period. Okay, so the moment you contract AIDS, there'll be an incubation period like in all diseases, but here you have it for 1 to 3 weeks. Okay, in this case, you will have nothing coming positive. Definitely not the antibodies. Antigen is also query, right? But they do say that, this GP24 antigen of virus, the HIV virus, starts showing between, some 10 to 28 days. That is the, long period of uncertainty when the antigens start showing positive. After exposure to the virus infection, then there comes a window period. This is when there was a incubation period, then comes a window period. Now, this window period is also pretty long. It's for 12 weeks, 3 months. Here, important thing is that antibody titer is not detectable. Okay, so the antibody titer in the window period is not detectable, and mind you, all the HIV tests that you've known of, the ELISA test, the rapid test, they're all dependent upon the antibodies, not the antigen. Okay. So these tests will also come negative. So that means now we spoke about 3 weeks, then we spoke about 12 weeks also. Okay, so straight away for 4 months, nothing is coming positive, despite the fact that you've already contracted HIV. Then comes a stage of primary infection, which is highly infectious, and with the CD4 cell count being near normal. So if you start showing, fine, okay, HIV has happened, we can't see the antibodies, but let's go for seeing the CD4 cell count, because it will be attacking the CD4 cells, right? So they'll go down, but even that does not change. Okay, so till you've reached the primary infection, but CD4 cell count still is maintained. Then comes an asymptomatic but infectious period. You had an asymptomatic period before, but now we have an asymptomatic infectious period, which is for 3 to 5 years with detectable antibodies. Now you can see the antibodies. For a period of, let's say, 3-4 months, you had nothing to show. Okay, you contracted HIV, but you did not have any test to show that there was actually you were contracting or you had HIV. So it's asymptomatic but infectious period in which you will have detectable antibodies, which will show in ELISA test, which will show in your, which will also show in your rapid tests, those kits of HIV. Then we talk about early immunodeficiency. As the name suggests, here the CD4 cell counts start decreasing, but they are always above 500 cells per microliter. Remember this figure of 200 so 200 copies or 200 cells per microliter. That's your cutoff for severe, severe AIDS. So 500 and above is okay. Then there is an infectious period, again for 2 to 3 years, with subtle symptoms and signs of immunodeficiency. So here again you have CD4 cell count decreasing further. So it comes between 200 to 500. And after another 1 to 2 years, there is full-blown AIDS with symptoms and signs of opportunistic infections. This is where most of the people, they succumb to HIV. Okay, you're trying to hold one thing, the other thing goes down. You're trying to, hold on to that thing or improvise that thing, and the other thing goes down. So your body is undergoing so much of trauma through so much of infections, and very dangerous infections, because there is no fighter mechanism inside your body. So you're falling prey to every next opportunistic infections, we call them, because they got an opportunity to flourish, otherwise they wouldn't have. Okay, and you're falling sick to all those things. Finally comes the terminal illness, when the CD4 cell count becomes 200 cells or less, and that's probably the end of it. So this is, it takes around 10 years or more for the full-blown AIDS to take place. So we have this 10 years window period in which we can help the patient. That's the idea which I wanted to tell you.